already. So this one is more about adaptive interventions, and we're going to move into pragmatic trials. I thought we'd do a little bit of review. It's been a month, and some people weren't at the last one. So we talked about the orbit model, the MOST framework, and a bit about adaptive designs. And then the new stuff for this class will be a specific type of adaptive design called SMART trial. And then we're going to talk about pragmatic research, so the distinction between pragmatic, versus explanatory trials. So a little bit about definitions, assessment, and then talk about some types of pragmatic trials. And today, we might not even get to it, but if we do, we're just going to cover the preference-based trial and leave some of the others for next time. Sound good? All right, let's do it. So back to the orbit model. If you remember a couple of classes ago, we looked at a number of different models for intervention, development, and testing, and then we focused in on this orbit model, which places more emphasis on the early phases of design. Hi, come in. Just getting started. Review. Awesome. So how the orbit model focuses more on designing the intervention, determining the clinical question, defining the components, and then refining it using the different strategies we talked about. So we spent a lot of time on phase 1, then the define 1A, define, and 1B, refine. And then phase 2 is more just the proof of concept, which tends to be just pre-post intervention trials before we even get into the pilots and the efficacy. We haven't spent a lot of time talking about because that's the part everybody knows. So we did more of that in the first class. And then as part of the treatment optimization phase, so sort of 1B, we talked about the MOST, multi-phase optimization strategy. So the way they define it is a comprehensive principled engineering-inspired framework, really just an approach for optimizing and evaluating interventions that are multi-component behavioral things, like our exercise interventions, or some of the psychosocial interventions, or the mindfulness-based, the Tai Chi, all those sort of ones that have many different treatment elements. So MOST includes a randomized controlled trial to evaluate the intervention, but before we get to that, there's lots of other phases that you need to do. And so the phases are aimed at optimizing the intervention using your own criteria that you select for efficacy. So if you recall, this was the drawing we showed you for most of this work, yeah. So, the idea is that you go through the optimization approach where you do some of these factorial designs we talked about, and you ask yourself the question, is the intervention optimized? If it's not, you go back and you just keep working on it. If it is, meaning that it actually achieves the clinical outcome that you predetermined, then you move into the evaluation phase. And if it's efficient or effective in an RCT, then you're supposed to release it. So we're going to get to what happens after you release it in a few classes. So that whole idea of dissemination and implementation, which is a big issue too. I guess maybe the people who did most weren't thinking about that. They were just trying to get the best intervention. So we talked about using the factorial designs as a way to optimize the treatment. And this was an example of a mindfulness intervention where we varied the duration of the classes. So the first 4 conditions had 4 weeks. The last 4 conditions had 8 weeks. And we also varied the length of home practice. So some of the conditions had short duration of home practice, and some of them had longer ones. And then we also varied whether or not the component of yoga was included. So some of the conditions had in different patterns, right? So some of the conditions had yoga and other conditions didn't. And so you can group them in different ways and lump the groups together to compare your questions of interest using the same participants across these 8 conditions. So the way they're grouped now compares all the conditions who had the short duration with all the conditions who had the long duration. So when you lump the findings of these 4 groups, compare them to these 4 groups, just using your repeated measures ANOVA or whatever, that answers the question of which is more effective, short or long. And you just sort of ignore the other ones. And then when you lump them this way, by comparing the groups that all have short practice with all the groups who have long practice, so again, the same groups, same participants, you reuse them to answer each of the clinical questions. When you lump them that way, so you add together 1, 3, 5, and 7, figure out their pre-post means, compare them to 2, 4, 6, and 8, that answers the question of which is better, short practice or long practice. And then when you lump them together this way, so you add together 1 and 2, 5 and 6, that answers your question is which is better, yoga practice or no yoga practice. So you answer each of the questions independently using the same participants. So it's a really clever way to optimize your use of participants and answer different research questions in the same trial. So rather than doing like an RCT with tons of arms or having to do repeated small studies, you can do it all in one. And so I think for people who are developing interventions, this is a really good way to test out those questions you might have, like for an exercise intervention, do they have to come in twice a week or can they come in once a week, right? How about if we do some online support included or not, right? How about, does it need to go for 12 weeks or can we do 6 weeks? Do we need to add booster sessions at the end? So any of these questions you can set up in a design like this and answer them all at once with a lot fewer participants. Then we talked about adaptive designs and went through a few videos about what do we adapt. So most commonly, as we go through, we can adapt the randomization allocation, so which is like how many people are assigned to each treatment arm based on the results we're already getting. And so I gave some examples of where people were dropping out more from one condition, like the sleep study, where the people were dropping out of mindfulness, but they were staying in the cognitive behavior therapy. So then we had to adapt the randomization to get the numbers equal again. Another reason you might, or another sort of condition for adapting randomization might be the opposite, who's responding better. So if you find at a certain set point, you look at your two treatments and the people getting one condition, they're doing way better, you can actually load more people into that condition because you're going to try and optimize it. Another adaptive design, and the key with adaptive designs is they're supposed to be, all this is supposed to be decided in advance, right? So I was giving examples last time of I've done these things, but they were all done sort of after the fact or ad hoc. So they weren't planned to be adaptive designs, but they were adapted just for practicality. So you can also plan to say, I'm going to recalculate my sample size partway through when I actually have data on the parameters I had to estimate, right? So I actually have data from this trial on, say, the preliminary effect size or how highly correlated scores are from different cohorts or something like that, which would have affected your sample size calculation. So you have the real data on those parameters rather than estimated data, then you can go in and recalculate. And you may need more people, you may need less. Hopefully you're hoping for less. Because often we underestimate these things to be conservative. And we talked about what's called group sequential designs, so how you can sort of be more efficient by lumping together phase 2 to 3 trials. So, sort of starting with a phase 2 trial and then using the same participants once you've sort of figured out which treatment arms are most promising, and then move into a phase 3 by recruiting another control group or something like that. And they talked also in one of those videos about the pruning designs, which is where you start with a whole bunch of conditions and you get rid of the ones that are not performing well, and then you just hone in on the most promising ones and carry those forward into like a phase 3. So that's all review from last time. Is there any clarifications needed on that stuff, or are we all up to speed? More or less? Okay. So continuing on the idea of adaptive designs, there's this idea of adapting the intervention. So in this case, like when you change your randomization allocation or your sample size, you're not changing the intervention itself, right? You're actually just changing the design to determine your efficacy. But you can use, you can create interventions that are themselves adapted as you go through the testing process. And so the definition of this is interventions in which the type or dosage of the intervention, okay, so it might be a totally different intervention. You might say, we use our example of mindfulness and Tai Chi or something, right? They might start in one intervention, and based on how they're responding, they may actually be transferred into a different intervention. Or the dosage could be changed. So it's all based on individual response. So the intervention is flexible, but it's also, well, you'll see when we get to the design, it's also very structured. So the dosage or the type of the intervention is individualized based on the patient's characteristics or their clinical presentation or their response, and then adjusted over time in response to their performance. So there's all sorts of terminology here as well. So they're also called dynamic treatment regimes, which I'd never heard before, adaptive treatment strategies, multi-stage treatment strategies, or treatment policies, which I've never heard either, but that's probably more in a public health sort of way. Yeah, so examples of how you might adapt your intervention. So I mentioned dose, type of treatment. Has anyone come across studies like this? Have you seen it done clinically? Any examples anyone can think of?
So, I mean, but it's a drug.
Yeah, it's often done in drug
Yeah,
clubs.
so it's like Vyvanse is a sort of the ADHD medication that was used for depression and was combined with an anxiety drug for cancer patients as well. But Vyvanse in children needs to be dose titrated. So I've seen designs where they've tested Vyvanse 10, 20, 30, 35, 40. So it's almost like 5 or 6 ranges of doses tested in the same study with a sample of about 150
With the
kids.
same participants, so with the same participants, if they don't respond to a lower dose, be moved up to
Yes.
a higher dose?
Mhm.
And if they do respond to a lower dose, something different happens to them?
Yes.
Yeah, so that's an adaptive design, or an adaptive intervention, tested with, it could be any kind of design. So you don't see these too much in behavioral trials, but I found there's a great website that's run by the woman who came up with most, and the next one I'm going to tell you is about, it's called SMART. Her name's Linda Collins, and she has a website, I think it's at Penn State, but if you look her up, she's got a whole bunch of examples of adaptive interventions, and I'm going to show you a few of them. So there's this thing called SMART trial, sequential, multiple assessment, assignment, randomized trials. So it's funny because I never knew what SMART stood for. Right? Oh, yeah, I know what a SMART trial is. Sequential, multiple assignment, randomized trial. So SMART trials are the methodology for coming up with the best way to adapt these interventions. So there's multiple intervention stages. Each stage score corresponds to one of the critical decisions involved in the intervention itself, right? So what's another example? So for example, you could also use it for compliance, right? So say you're doing an intervention, and some of the people are going to come to all the groups and some people aren't, right? So you set that as your decision point. So halfway through the intervention, you can look at attendance, say, or home practice, and like for an exercise intervention, right? So if they're not attending, they go into the no category and you try something else, right? And if they are attending, great, maybe you leave them alone and keep it going. So there's these decisions involved in what's the next step in the intervention. So each participant goes through all the different stages, so you're not recruiting new people for each question. At each stage, the participant is randomly reassigned to one of several intervention options. So it maintains the rigor of randomization, but also the flexibility of, okay, this didn't work, let's try this, right? But really in a structured way. So the SMART trials are used to develop adaptive interventions as opposed to confirming that a particular adaptive intervention is better than control. So they say that after you do your SMART, well, then you do your RCT, right? So these fall in the same category of like the most trials where you're optimizing your intervention. It's another way to do it. Like you could do the factorial design and you can do a SMART design. And actually sometimes when you lay them out, they're almost the same in terms of analysis and that. So they say SMART should be followed by a confirmatory RCT, comparing the adaptive intervention to maybe the best usual care or another intervention. So this is your generic SMART design. Anyone seen this? Not yet? Okay, so you've got, these are your pool of people here at the beginning. And they're randomly assigned to treatment A or treatment B. Okay, and we'll use specific examples in a minute, but put whatever you want in your mind as treatment A. Let's use exercise, and actually these are often used for drug compared to behavioral, right? So say maybe, what would make sense? So say you're treating cancer-related fatigue, and you want to compare exercise to some kind of pharmaceutical, maybe you'd do that, right? And then in treatment A, there's diamond here is your question point, so you set a criteria. So after 6 weeks or 8 weeks or whatever it's going to be, you're going to have a very objective measure of whether or not they're responding to this, right? So are they attending? Is their fatigue improving? Is their quality of life improving? Whatever it is, you set a marker, and we talked about clinical endpoints before, right? So what are you trying to achieve? We want a 50% reduction in fatigue. So if they have that, then they get yes. If they don't have that, they're a no. And if they're a yes, so say they responded to the intervention, their fatigue is improved, they're either done, maybe, in the next randomization, or they get a lower dose, or they get a maintenance or something like that. So the yes people here form one group, and they're re-randomized. So then in essence, it's like another RCT. With this population, you're testing these two possible things. And so the no people, they're another population here. And so say they don't respond to your fatigue intervention, they're still fatigued, what are you going to do? Maybe you're going to try a higher dose of the treatment or the drug. In this case, the treatment. So maybe they need more exercise. Maybe they need a longer duration of exercise. Or maybe they need something else, so you could switch them over to the other treatment. Right? And then you do the same thing with treatment B. So say treatment B is the drug, do they respond? Yes, if they respond to the drug, and et cetera, they could be finished, or they could go to a lower dose of the drug, right? You could have the same options as above. If they don't respond, again, you could try a higher dose of the drug, or you could swap them to the other treatment, the exercise. Does that make sense? Does it look cool? I think it's cool.
I feel like you'd need such a massive sample size for that.
Well, actually, you need fewer people, right? Because, well, I don't know, I haven't actually ever calculated a sample size, but you need fewer than you would to individually answer all these questions.
I guess that's true.
Right? Because you would need, okay, this is one RCT,
Yeah.
A versus B, done, right? Adequately powered. This is another RCT, right?
Yeah.
This is another RCT, this is another RCT,
Breaking
this is
them up as
another
you go
RCT.
along, yeah. So
Yeah,
it's
and they would all
groups
need
would get
new people,
smaller.
right?
Yeah.
So these are all the same people.
Yeah.
So you get more bang for your buck. Yeah, I don't know, you'd have to calculate, I actually haven't read through how to calculate sample size, but I think you'd start here.
Yeah, because your groups get smaller
Smaller and smaller
It's
as you
hard
go
to
along.
predict who's going to respond, how many people are going to respond and how many aren't.
That's right. Yeah, so you might have to do, some adaptation in your randomization sequence or something like that.
Cool.
You could, if you knew enough, you might be able to predict response rates from previous research. Yeah, it's kind of cool. And, I've never done one, and I don't know too many people who have, but I know there's a lot of interest in it. So here's an example. There's a whole bunch of examples on the page of that. I think her thing's called research. I can't remember what it's called, so I have the analysis factor in my head, but it's something like that. It's some analysis institute, and she's got a bunch of examples. But here's one where they did, we're treating, say, pain, and comparing a medication to a behavioral intervention. Right? So, there's like, say, an opioid to mindfulness, right, is possible, or some other kind of behavioral intervention, the same thing. But in this case, the responders, so the people who responded to the medication, they just stayed on it. So they didn't re-randomize this group, right? Whereas in the previous one, if they respond, they get two different options. But you don't have to do that. You could just have 6 arms, right? Or you could even, have fewer, like, they could just have 2 maybe here or something. But then the non-responders, that's the problem, right? So what are you going to do with these people who don't respond to the medication? Well, you can increase their dose, or maybe you add the behavior, right? Mm-hmm. So it's like, the opioids aren't working, let's add some mindfulness to this and see if that'll help. Or maybe it's motivational interviewing, right? Because that helps with treatment adherence. We need Kirsty here because she's just designing a study on this, right? Yeah, so maybe that's a good thing to look at. So medication alone, maybe the behavioral intervention is motivational interviewing. The same thing, so if they respond, right, and they start to improve, they will continue the behavioral intervention. But if they don't respond, we try different things, increase the dose, right? Maybe they just need more mindfulness or more whatever it is, more motivational interviewing. But then you can also add the medication. So this group here ends up being the same as this group here, just in a different order.
Yeah.
Right? So that's kind of
cool. Yeah. It's
yeah.
really cool.
Yeah.
And then how do we report? Like, how do we report these findings? Like, will it be an R? Like, will it be a predictor value? Or is it what's
like what stats do we do on them?
Like, yeah, like what's is it the amount of variance accounted for by one intervention to the other? Like, how do we add these two things?
Well, I think you would probably compare groups in like a linear mixed model type approach, right? Where you would have fixed factors for the groups and then random factors, and that's a whole other thing, right? But if you look at I put a couple of articles on D2L about this, and I think some of them get into the analysis, although I didn't really, read too much about that because I've never actually done it. So I think if you decided to do it, you need to read quite a bit. But there's on the website, the Linda Collins website, she's got these diagrams. Here's another one. This is from her website. She's got about 10 or 12 of these from real studies that people are doing. So this one was interesting here, I thought, because they're doing 8 groups. Most of them don't do 8 groups at the end. Most of them, if you respond to the first treatment, they leave you alone. Or they either maintain the dose or they just take it off and see what happens. This one was, let's see, this was for something called reinforcement-based therapy, and they're looking at compliance. I think it was either smoking cessation or trying to get them off drugs, or it was some kind of addictions thing. So they're randomized to either traditional or reduced therapy. So this would be like your full dose, and this would be, your scaled down version, right? Which would be an interesting question for some of these exercise studies or the mindfulness studies, right? Like, do you really need to do 8 sessions with 45 minutes of home practice? Do you really need to come in twice a week and do your exercise, right? And so the reduced version would be, say, 4 weeks, or just something you wanted to see if it would be equally effective based maybe on the literature, right? Because there's a few studies that have done 4-week programs and they seem to work with only 20 minutes of practice or something. Yeah, and then you come to the question point, whatever it is, right? Do they do it? In this one, if they do the traditional thing, that's the yes, then they get the reduced thing, right? Half of them, and the other half to stay on the traditional thing. And then you can compare. Again, do you need to keep doing the traditional thing, which is going to be more resource intensive? If they don't reply to the traditional thing, they either keep doing it or they up it. They up the ante and make it even more intensive, right? Because these women aren't responding. But you wouldn't want to give this enhanced thing right at the beginning, because some people actually will probably do better on reduced, right? So you're trying to, maximize your bang for the buck. And so the people who start on reduced, again, if it works for them, great, stay on reduced and try an even less version. So there's abbreviated, which is even shorter, right? So maybe that's only 2 weeks, so you've got the 2 weeks, the 4 weeks, and the 8 weeks or something, right? The reduced, the abbreviated, the traditional, and the enhanced. So there's actually 4 levels of the treatment intensity in this study, right? So you're trying to get people to the right level for them. And so if it didn't work, the reduced version, then you have to up it, right? Keep them on the reduced or up it. So then you've got these groups who are all on different levels based on their response. Yeah, and then how you analyze it, I guess you could lump groups together, like a lot like the factorial designs, and answer specific questions. So, make sense? Everyone wants to do a SMART trial? I think it would be really cool. Like Julie, we were talking today. You might be able to work that out. The only issue is the numbers of people that you need, right? Because when you're dealing with a small population, it can be tricky.
So, what's the consensus regarding definition of dose? How do we define a dose in behavioral therapy? Is this how we have?
Well, it's based on what's been done previously, right?
So is it like time into duration, just like a drug, or is it because like a drug is pretty clear, it's like 70 milligrams once a day.
Or it could be 35 milligrams twice a day. That's
Right,
an empirical question. So the dose would be, I think you would start with, well, what have people done, right? And it depends where your field is. So in exercise, what's a standard dose in exercise interventions in cancer?
Usually twice a week for 12 weeks.
Yeah, so 24 sessions, right? Twice a week. So you could mess around with the dose. That might be the traditional one, right? So you could do, that's a lot, right? Twice a week for 12 weeks. So you could try once a week for 12 weeks, or you could try twice a week for 6 weeks, right? And you don't know necessarily how they're going to go, but a study like this would really help you figure that out. Like, this would be a really good design for getting the dose right,
And even in the twice a week, we know the exact duration of time. Does it recommend, is it 30 minutes twice a week for 12 weeks?
60 minutes.
60 minutes.
60 minutes.
It has to be a minimum of something.
Well, I think they aim for the recommended 150 minutes of moderate to vigorous activity a week.
Right.
And where does that comes
That's
from?
just the standard.
But how did it become a standard, right?
I think that's what's I guess.
Yeah, but why is it recommended? Is that the amount that shows maximum physiological, or just enough, training benefit to have a health effect? It's good to ask that question. Where did they get the 150 from, right? So if we're all basing it on they've got to get 150 somehow, where did 150 come from?
Yeah, I think we've accepted it for a long time.
It may be based on something really sound, but maybe it's not, Yeah.
The issue with the 150, it's for everyone across the board. Someone who's younger, older adult, someone who has chronic disease, healthy, it doesn't matter, it's across the board. And a lot of the times when you're looking at that number, what you have to achieve and all the strength training you have to get per week, it's very overwhelming. And I think it's just a lot of people are set up for failure before they even start.
So this kind of trial would be so useful in a specific population to ask that question, because it's got 4 different levels, right? It's got abbreviated, reduced, traditional, enhanced, right? And you can define those based on, you go in the literature and try and figure it out. Is there a range of recommended dose, right? Because I know, Christine's been doing these studies looking at 150 minutes versus 300 minutes. And, is there, what's the minimal amount you can get to get the maximal benefit in terms of, lipid profiles and endocrine levels or whatever she's looking at. So you could look at all those questions in a trial like this. Yeah, and what the dose for meditation, it just comes from, John Kabat-Zinn invented this program that was 8 weeks long and 2.5 week session, or 2.5 hour sessions a week, plus 45 minutes of home practice. That's not based on anything other than his idea of what might be acceptable to people, right? And now there's accumulating evidence that works, but there's very little evidence showing what else might work. right? That's more minimal. I mean, lots of people have done 4 sessions. That seems to work to some extent, depending on, you know, you have to really think carefully about what's your question here, right? How do we define a responder? You know, and it would depend. Are you looking at pain or fatigue or just compliance? You know, what is it that you're trying to achieve? But I think that would be pretty cool. So there's other examples of that on their website. You know, with many, there's like a sleep one. There's one where they're comparing, and these are real trials that people are doing. So there's one in cancer where they're comparing, actually it might not be in cancer, it's Charles Moran, but they're comparing cognitive behavior therapy for insomnia to a drug trial, or a drug, like a sleep pill, and starting at the beginning, right? But then if you don't respond, you know, you get the other thing, which is great. It's a much more efficient way to, you know, allocate resources instead of giving people stuff they don't need, right? Just give it to the people who actually need it.
And one study answers so many questions.
Yeah.
You know, it's like, it can really help inform a really nascent kind of literature where we don't know much.
Yeah, and it's almost like taking a step back. Like, okay, everybody does this, but like, why? Why are we doing that, you know? And is it absolutely necessary? And those are the kind of things that funding agencies like, too. Right? Because there's geeks like me on the panels going, oh, I love that methodology. I really want to encourage someone to use it, right? And it answers so many questions. So funding agencies love that stuff. And it's like, you know, oh, we could be more efficient. We could optimize our use of resources. So just to summarize this section, so we talked about intervention development and different stages, focusing on the orbit model. You know, and really thinking about stepping back. And before getting into these RCTs, to look at efficacy, we need to optimize the intervention elements using different adaptive designs. We can use the MOST framework. We can use SMART designs to really optimize the interventions to suit individual differences more in clinical settings. And it's only then that we move on to these traditional RCTs. And even then, you know, some of them have downsides as well, right? And then what do we do after that? We'll get to that later. So any questions about this stuff? Or we're going to go on to pragmatic trials now. Yep.
I'm curious, other than sample size, are there any other drawbacks to that type of intervention study?
Like a SMART one?
Yeah.
Well, let's think about it. Do you want to look at this one? What could be the drawbacks? You know, I don't even think sample size is a drawback, unless you wouldn't have tried to answer all those questions in different ways, right? Because definitely compared to the other ways you can answer those questions, it's more efficient. Would it be difficult to recruit people? Because they're going to be randomized, they don't get to choose, but they're getting similar things. I guess it might be a little messier in terms of doing the stats, because you're going to have smaller numbers in all the groups. I don't know, what else can you guys think of that would be drawbacks?
Just require a little bit more setup time, but that's not really a drawback, I guess. Because you have to pre-specify all of the things. It's like, didn't comply, didn't comply, what's your boundary for compliance?
And it's more time sensitive, right? Because usually these decision points are like at a certain point, like after 4 weeks. You know, are they responding or not, right? So you have to be really on the ball in terms of monitoring everyone carefully, but you should be anyway. You know, it might require additional resources of staffing to work through all this. Yeah. But for the participant, they might not see much of a difference, right? So say they get 4 weeks of something, and then the next 4 weeks they're getting something else. It might not even look that different to them. Unless it was, okay, you've been coming in once a week, now you gotta come in twice a week. I mean, that might be, and the consent might be confusing, the consent process, right? Because if you respond, you'll get either one of these two, and if you don't respond, you'll get either one of these two, right? So that might make it a bit harder to recruit people. Any other ideas? The other thing would be, so if it's a medication versus a behavior, there might be preferences, clear preferences, right? You know, some people are like, I'm not going to take opioids or sleeping pills or whatever. I want to do this in a behavioral way. And the other people might be like, I'm not coming in for groups. I just want to take a pill, right? So that's where the preference stuff comes in. So maybe we'll talk about that. Okay. Oh, we've got a nice video here. So, pragmatic trials. Let's see if we can get this to work. Come on, my friend. This doesn't want to go. Usually if I go back and forth at this time. How did I get it going before? Let's see. Might have to do it in here. Come on, baby. find it in, what's her name, Sandra L. Where's all my YouTubes? Oh, this is the website with all the different adaptive designs. Look at them all. Just look at a zillion of them. This is, it's called the Methodology Center. So these are all the projects using SMARTs, pregnant women who have used drugs, children with ADHD. And you can see they're all like little variations on the, yeah, so it's actually pretty cool. Yeah, it's really cool. Oh, here's YouTube here. This is my friend, Sandra L. I like this lady. So question 1, here it is. What is a pragmatic trial? So we'll just watch it this way.
The first people to use the word pragmatic in relation to trials were Schwartz and Lelouch in a paper in 1967. And they argued that most trialists didn't really think about the type of trial that they were trying to design. And in that paper, they make a distinction between what they call pragmatic trials, which are designed to answer a question about decision making in clinical care. What sort of care should we give to patients? And explanatory trials, which are designed to answer a question about causal research hypotheses about biological processes, chemical processes that are going on. And what they argue is that most trials are designed in a sort of explanatory way, but actually many of them ought to be designed to answer the pragmatic question about what sort of clinical care patients need. About 30 years later, there was a paper written in the BMJ where they express it slightly differently, but it's the same sort of idea, that pragmatic trials are those trials conducted in the real world or in routine clinical care, whereas explanatory trials are trials conducted under ideal conditions. So another way of thinking about that is to say an explanatory trial is asking, could this intervention possibly work in very tightly controlled ideal conditions? Whereas a pragmatic trial asks the question, could this intervention work if it's rolled out into the real world? So very often, people think of trials as drug trials, and in fact, if you read Schwartz and Lelouch's paper, that's what they're talking about, really, drug trials. But if you think about the way that they define a trial, a pragmatic trial, to try and decide between care options, then in fact that could be any sort of intervention. It need not necessarily be a drug. So for example, a reorganisation of the health service or education to patients, any of those things could be evaluated in a pragmatic trial. So, I mean, Schwartz and Lelouch's paper was written about 50 years ago, and the paper in the BMJ by Martin Rowland and David Torgerson was written in 30 years after that, so 20 years ago. But I think those two papers really give us the best idea of what these trials are, because they pick up on two things. One, the aim of the trial. Pragmatic trial is trying to answer a question about what happens in the real world, and also the difference between the two trials in Rowland and Torgerson's paper about the setting is really important. It's a real world setting in a pragmatic trial, whereas in an explanatory trial the setting is less important.
All right. Let's go back. Or I'm going to do something else here that might help. Speed things up a little bit. Back in here. So she said a lot.
While visiting an antique lamp shop, you accidentally release a powerful genie.
Whoa, where did that go?
And out of gratitude, the genie makes you an offer. The genie will grant you a storybook life, filled with adventure and challenge, both successes and failures, love and heartbreak, bittersweet and beautiful.
The hidden side of clinical trials. I might have to, TEDx Madrid, I might have to watch that one. All right, let's get back to this. Okay. All right, so she talked about explanatory or pragmatic, pragmatic versus explanatory. So we can summarize sort of what she said in a number of these different slides, right? So if you ask the question of what, so an explanatory trial is your traditional stage 3 efficacy trial, right? So the question is, can treatment work? Is it efficacious? We're maximizing the internal validity, testing a hypothesis. The circumstances are well controlled and ideal, right? Whereas on the pragmatic end, and this is like a scale, right, a continuum. So, and we'll see in a minute that you can actually rate just how pragmatic any given trial is. So here we talk about effectiveness. So there's that efficacy, effectiveness domain, again, that people often confuse, right? They say, is it effective? But when they're talking about an explanatory trial that's testing efficacy, they use it generically. So this is usual care. Why do you do it? Well, there's different things on this, but in this slide it's saying, you know, really with the efficacy trials, we're looking at cause and effect. That's why we randomize, because we can make causal inferences. The pragmatic trial is more about making decisions about treatments. So policymakers, like what are we at about clinical questions? How do we do it? By maximizing generalizability here. So we really want this to reflect what happens in the real world. You know, how do we make cause and effect conclusions? By minimizing the variation and having a very rigid protocol. Who's included in these trials? Again, very selective inclusion criteria, quite narrow, maybe just one type of cancer, one stage of cancer, right? We're just going to focus on head and neck cancer patients, or we're just going to do stage 1 breast cancer patients, whatever it is. If you're more pragmatic, you have broader inclusion because that improves your generalizability. What are the methods you use? If you're going to be pragmatic, you're just going to be collecting the data that you would normally collect in usual care. So someone will get a blood test normally, someone would get a scan. There's nothing extra added in there. And the outcomes, because you're using what's used in clinical care, then they're clinically relevant, right? So, you know, every time a person comes to get their chemo, they get their blood cells counted, and you can use that as an outcome, you know. So have they got more or less anemia, right, if you're studying fatigue. In a more explanatory or efficacy trial, data collection is, you know, usually way more than you would do in usual care, right? There's this extra battery of questions. They have a big package they have to fill out every time they come in, you know, maybe you're taking blood samples. And the outcomes are relevant to answering your research question, right? What's the mechanism of change? What are the biomarkers? But they may not be that clinically relevant. So this is sort of the continuum. And here's another way that's a little more detailed. And if you look these up, there's a whole swack of them on there, and they're saying fairly similar things, right? So if you look at each sort of part of your study design, this is your efficacy trial or your explanatory trial versus your pragmatic or effectiveness trial, right? So the question is, can this treatment work under ideal circumstances? And in your pragmatic trial, it's, does this treatment benefit under usual circumstances? They're not always the same answer. So again, the participant eligibility is very strict versus very broad. The intervention as it's delivered in your efficacy trial is very, very structured. It's manualized, right? We do 2 sessions a week for 60 minutes, and that's all we're going to do, right? We're not going to be flexible. But in the real world, in the pragmatic trial, you know, you can see it. Everyone's going, ooh, it's terrible. You know, what this would be so hard, you know, because everything being so wishy-washy and highly flexible, right? So we're trained, and everyone's probably noticed it, we're trained to do efficacy, right? Like, we're looking at this, the pragmatic, and going, oh, ooh, you know? But there's a push more towards this end, right? Because there's benefits, too. So your comparison intervention, again, is inflexible, right? This is exactly what it's going to be. Strict instructions, you know, compared to usual care. You know, some people will get this, some people will get that. They might not all get the same thing, right? Your practitioner in your efficacy trial is highly trained, highly monitored. We look at treatment fidelity. We make sure they're doing what they're supposed to do. In an a pragmatic trial, you know, there could be all sorts of people doing exercise interventions or delivering hypnosis or whatever they're doing, or doing CBTI, right? They may not all be these highly trained, you know, supervised clinical PhD level, whatever. You know, they might just be nurses in a community care setting or something. Participant compliance is, you know, monitored closely. If people miss a session, they're called and told, you know, make sure you come. Right? There's a lot of effort put into making sure that people comply in your efficacy trial. You know, in an effectiveness trial, it's well, they're going to do it or they're not going to do it. You know, that's that. Right? Let them do what they're going to do. Practitioner adherence to protocols, so same thing. We do fidelity monitoring. We make sure they do what they're supposed to do. Well, you know, we don't really know what they're going to do. Either no or very unobtrusive measurement of adherence, no special strategies You know, there's no workshops or anything like that to train them. They just get what they get. So the follow-ups in your efficacy trial are frequently, they're intensive follow-ups, there's lots of data collected. You know, in your pragmatic trial, you'll just get the data that they would probably normally collect clinically, and that's all you get, there's nothing extra. Your primary outcome in your efficacy trial, it's restricted, composite outcomes, you know, all sorts of different things. You know, for example, if it's a clinical outcome, you want your expert to be blind, who's recording the extent of the symptoms or whatever it is, right? And that would never happen in the real world. You know, your nurse is saying, oh yeah, your eczema's gotten better, right? Whereas I'm thinking of a mindfulness trial for eczema where they had, you know, blind experts measuring the size of the eczema on the person, you know. Great, I mean, that's the only way you're gonna know for sure, but it's not practical. And then it talks about your analysis. Might try and just include or exclude non-completers and non-responders, so you're just doing per protocol analysis, and whereas you would always use intent to treat in your pragmatic trial. So thoughts on those? So, not surprisingly, there is a tool to measure how pragmatic your trial is. And I have a video on it, and it probably won't work. So I'll have to find her again. So let's see, which one is she? It doesn't say which number it is. Let's see if we can find it. It's the same lady. So we want
the precise tool.
There it is. You can watch all of these. You can enjoy them all. We'll watch this one next.
The PRACY2 tool was designed to help trialists when they're designing their trials. So Schwartz and Lelouch in 1967 make the point that although a lot of trials ought to be designed as pragmatic trials, in fact trialists naturally veer towards designing them as explanatory trials, when pragmatic trials would be a lot more appropriate. So the PRACY2 tool was designed to help those who are designing trials think about designing their trial as a pragmatic trial. So it has 9 domains: eligibility, recruitment, setting, organisation, flexibility of delivery, flexibility of adherence, follow-up, primary outcome and primary analysis. And those 9 domains together kind of cover different elements of a trial that are handled differently if you're thinking about an explanatory trial or a pragmatic trial. So the way that the tool works is that you take each of those domains and you score them from 1 to 5. 1 meaning it's handled in a very explanatory way, and 5 meaning it's handled in a very pragmatic way. And those scores are then plotted on a wheel. And from what the wheel shows, you can tell whether your trial is very pragmatic, very explanatory, or somewhere in between. So I've got 2 wheels, which I'll just show you to give you an idea. The first wheel is for the REVA-2 trial. That was a trial of rapid HIV testing done in UK primary care. And this was a cluster randomised trial. And actually you can see from the wheel that for most of the domains, in fact for all of the domains, the trial scored a 4 or a 5. So you get this nice big wheel of a pragmatic trial. The next wheel is slightly different. This is for the WAIT trial. Now the WAIT trial was a trial of Montelukast for children with who might wheeze. And it was done on preschool children, and the way the trial was set up was the Montelukast was given to parents, and they were told to administer the Montelukast when the children had certain symptoms. So some of the parents were given the Montelukast and others were given placebo. They didn't know whether they had Montelukast or placebo. Now you'll see in this wheel there are 2 particular spokes, or 2 particular domains, which have scored nearer to the explanatory end of the scale, and they are recruitment and follow-up. And the reason why they've scored nearer to the explanatory end is that, say, for the recruitment, this was a very large trial, and we needed to get enough participants into the trial. So they weren't only recruited in the setting where the intervention might be used if it was rolled out, but they were recruited from other settings. So that makes it a little less pragmatic than it would be otherwise. And the follow-up was also less pragmatic because in this trial, for safety reasons and other reasons, the parents were followed up frequently by telephone call, and then also required to fill in a diary of their children's respiratory health. Now that wouldn't happen in real life, but it was very useful information for the trial, but it made the trial a little less pragmatic in that aspect.
Okay, let's make sure we stop this. Okay. Slide. So we'll summarize that. Oops. There we go. So this PRESI-2 tool, has anyone ever heard of that before? No, see, you're learning about tons of stuff. It's like anything that you might want to do, there's some way to evaluate how well you do it, right? When it comes to clinical trials. And we're gonna, just heads up now, we're gonna do this on the match study in a little while. Although I don't have the diagram, but we'll give it numbers. Yeah, so there's all these different areas, right? And so remember she said they're scored on 1 to 5. So 5 is the most pragmatic, 1 is the least pragmatic, or the most sort of explanatory way. So yeah, ask yourself for eligibility. Oh, hi, Kirsty. To what extent are the participants in the trial similar to patients who would receive the intervention if it was part of usual care? Right, so you can see how there's a range on that, right? So say you're studying cancer-related fatigue. If the participants in your trial all have cancer-related fatigue, then, and it would be any type of cancer, right, then you would be more like a 5. But if it was people who had no other problems and no comorbidities, or, you know, met certain other inclusion criteria, it would be more like a 1, right? So the broader your eligibility, the higher your score would be on that item. Recruitment, how much extra effort is made to recruit participants over and above what would be used in the usual care setting to engage with patients. So how hard are you working to get these people, all right? So I mean, if you think about the match study, it's getting a really low score there, because we're working really hard, right? But if you're just walking into clinic and taking the people who were there, then you're not, there's no extra effort, right? So that would be more like a 5. So the setting, how different are the settings of the trial from the usual care setting? So you have to know what your usual care setting is first, right? So say you're, you know, bringing people into the lab and they're doing their exercise interventions. Well, that's probably not where they'd get it in usual care. Well, it's not part of usual care, right? So that's a harder question to answer. So what would be usual care for an exercise intervention? Probably should be in the clinic, right? Should be more accessible. And then there's questions about the intervention and its delivery. So organization, how different are the resources, provider expertise, and organization of care delivery in the intervention group from those available in usual care? So think about most of the trials we do, they're totally different, right? Some of them, they're closer to usual care when we use the staff in the clinic. So if you're training nurses to do an intervention that already work with the patients, right? So then that's closer to a 5, you know, that's more pragmatic. If you use the counselors that are in the psychosocial resources program, that's better. If you do recruitment, you know, with the clinical clerks, say you use the clerks to do the recruitment, that's better too, right? If you look at all our screening for distress work, you know, we try to embed it into the usual care procedures. So they come in for, you know, they check in at the registration desk and they're told by the clinic staff to go and fill out a questionnaire about their distress, right? So that's embedding it in the organization. For one of the trials, we actually had to have a research assistant sitting there making sure that happened, right? So that's a lower score for pragmatism because you're putting extra resources in. Flexibility in delivery. So how different is the flexibility in how the intervention is delivered from the flexibility anticipated in usual care? You know, so if you're very rigid, you're making them come in twice a week to do their exercise, right? That's a hard exercise, a bit harder because it doesn't happen in usual care necessarily, but you have to imagine if it was going to be transitioned into usual care, what would it look like, right? Who's going to be delivering it? You know, how are people going to do it? Like I imagine if they're inpatients, they're going to do it kind of whenever they feel up to it. If they're outpatients, it's not going to be as rigid as it is in your research trial, right? Even if they're doing it at home. So maybe usual care for exercise interventions is at home, right? And so how would people do it at home? Would they come in twice a week or, So there's that question about how flexible is your delivery. Flexibility and adherence. So how different is the flexibility and how participants are monitored and encouraged to adhere to the intervention compared to, again, what would be anticipated if this became usual care, right? So we'll go through this for match in a little bit after I tell you more about match. And then the follow-up. So how different is the intensity of measurement and the actual follow-up questionnaires in the trial compared to how people would be followed in usual care again? And if usual care is improving, so for example, we've implemented the screening for distress called Putting Patients First questionnaires that they are supposed to be getting on a regular basis. So usual care is better in terms of monitoring patients, but still probably we're adding in extra things in most of the trials. So the analysis of outcomes, primary outcomes, to what extent is it directly relevant to participants? And is the analysis, or all data. So that's that idea of you doing intent to treat or like sort of taking out the people who didn't comply or didn't, finish the intervention, right? So you, again, rate each of those dimensions on 1 to 5, add them all up. Well, you actually plot them on the wheel. I guess you could add them all up too and get a total score. So that tells you where on the scale from explanatory or efficacy to pragmatic or effectiveness that your trial falls. Okay, so we're going to go through and do a little rating exercise on the match study after everyone's up to speed on it, so we'll come back to this. So she's talking about pragmatic trials very generally, right? These effectiveness trials. And so there's many, and again, it's a continuum. So any kind of trial has got some degree of pragmatism or not, right? So you can use that for SE tool, and the lowest score, I guess, would be at like a 9, because they get 1 on all 9 dimensions, right? And the highest would be 5 times 9, right? So you can give yourself a score and see how pragmatic you are. But there are certain types of trials that are meant to be more real-worldy or more pragmatic. That's the whole point to them, right? So today we're just going to talk about preference-based trials, but other ones that are more pragmatic are cluster randomized trials, and she mentioned that in one of the videos. Stepped wedge designs and N of 1 designs. So next time, I think we'll do those 3. I don't know how our time is, but yeah, we'll just do the preference-based ones today, and we'll talk about the other ones another day. Okay, so preference-based trials. Why would you do this? So just generally, what a preference-based trial is that people get to choose in one way or another what they want. So why would you do it? Well, patients have preference, right? So are you trying to be more pragmatic? Are you trying to be more real-worldy? Like what would actually happen in usual care? People would choose if they want to exercise, right? They would choose if they want to do mindfulness. They would choose if they want to have acupuncture. So the other issue with efficacy trials is that patients who have a really strong preference, they are more likely to decline being in your RCT because there's a chance they might not get what they want, right? You explain it to them in informed consent. You say you might get exercise, or you might get, you might get, a pill or whatever it's going to be, right? If we're talking about the sleep stuff, maybe you'll get CBT, maybe you'll get medication, right? Or in depression trials, or maybe you'll get, like the one we're doing, maybe you'll get mindfulness, maybe you'll get Tai Chi. In a previous study we did that I'm going to tell you about, where they either got the mindfulness program or a support group, supportive expressive therapy. Well, people who are like, no way, I want the mindfulness, they're not going to sign up for your study because they're just going to go out and take a mindfulness class, right? So you lose all those people. And so when a large number of people refuse to be randomized, it doesn't represent the whole population, so your generalizability goes way down, right? That's your external validity, your generalizability, which is what the pragmatic trials are trying to enhance. And if the patients who have strong preferences, they still consent to randomization, they're like, well, all right, I'll help you, I'll be in your study, but I'm really hoping, I get the one I want. So they may be really happy when they get what they want, or they're going to be really disappointed when they get what they don't want, and this could affect their outcomes. So I'm going to show you what happened to us in a trial that was exactly this. So Mindset was a clinical trial where we randomized people, women with breast cancer, distressed breast cancer survivors, to the mindfulness-based cancer recovery, or supportive expressive group therapy, which is a traditional support group where they sit around and talk about their feelings, or the control condition was a 1-day stress management seminar. And then after a 4-month period, they were assessed at baseline, reassessed after they'd done the programs, and then the people in the 1-day seminar were reassigned to one of the 2 longer interventions. So these were their preferences. So we asked them, actually. We didn't let them choose, but we asked them, what were you hoping to get? And it turned out that preferences varied. So half of them were hoping to get mindfulness. This was in the early days of mindfulness, before everybody done it. 13% wanted the supportive expressive therapy, and 16% actually wanted the control condition, which was a stress management seminar. They didn't know it was a control. So some of them actually wanted that, and only 16% had no preference, right? And so then you look at what people got. Only 31% got what they wanted, whatever it was, right? So you've got 70% of people being disappointed and not getting the treatment they wanted. And then when preference is unequal, that's going to also affect what happens in your treatment arms above and beyond randomization, right? If there is a preference effect, which there was. So it doesn't look big, but this is a significant result where when you compare people who got what they preferred, so the blue line, no matter what they preferred, right? So if they wanted the stress management seminar and they got it, to the people who got something non-preferred, there was more improvement in people who got their preferred program, even if it was the control condition that wasn't supposed to do anything, right? And you see that even more here with quality of life. So there's a big effect of preference, right? So and we also saw in our primary results for this study that the mindfulness group did better than everything. Well, more people preferred it. So there was more people in their preferred treatment in that condition. So, and that condition improved more. Well, was it because the group's better, or was it because the people got what they wanted, right? It's a huge problem. So that's part of the reason we decided to look at preference as an actual design feature. And there's another study that I mentioned last time where this happened in a different way. So this is I Can Sleep. So this is for cancer patients with insomnia. And remember I told you we blindly assigned them to groups, right? So we just told them we were looking for patients with insomnia to do non-drug treatments for insomnia. And so they came into the study, and the idea was that we'd randomize equal numbers to the CBTI, which is a cognitive behavior approach to insomnia. It's very clearly about insomnia. You monitor your sleep, you do things about your sleep. It's very sleep related. Or the mindfulness program, which we knew helped sleep, but more indirectly. And so what happened, the idea with the way it was designed is that equal numbers would go in, equal numbers would drop out, and we'd have a nice equal thing. But I think I showed you this last time, but what actually happened is that patients had preferences. And so we randomized 111, but we had to, this is where I talked about adaptive randomization, we had to switch the randomization ratios to put more in mindfulness because they were dropping out. So we had 15% drop out of the CBT group, but 50% were dropping out of the mindfulness. And that's clearly, we didn't ask them their preference, but it's clearly because they got a non-preferred treatment, right? Because it's not obvious, if you have insomnia, why you would be told to meditate, So that's another example where preference messed up our study, because we didn't give people a choice. In fact, we didn't even tell them what the interventions were in this study, right? So you're trying to be rigorous when we talk about the efficacy end of the scale. We're trying to do an efficacy trial, right? And so we compromise the pragmatism by not, by assigning people to something that they would never have done in the real world to help their insomnia. So based on these experiences from Mindset and I Can Sleep, that's where we came to match. So in this case, it followed directly from Mindset, and the mindfulness group did much better than the supportive expressive therapy. And we thought, okay, we want to, keep comparing mind-body interventions to each other. And so what's the next one? It was kind of arbitrary, but also because there's growing evidence that Tai Chi could be helpful, and there's clinical interest in it. So we decided to, okay, we'll do that. But we're going to up the ante from Mindset, and we're going to add in preference. So it's a pragmatic, preference-based comparative efficacy trial. We're comparing the MBCR to a new Tai Chi Qigong group. And we did it the same way. So it's like basically a mindset plus another mindset for preference. So we asked people at the beginning, and I'll show you this as kind of an overview. So we asked people at the very beginning, we've got these two interventions, mindfulness and Tai Chi. Is there one that you think you prefer? And if they said yes, we have a preference, then that's what they got. They got the mindfulness or they got the Tai Chi, right? So this comparison here is a non-randomized comparison of mindfulness and Tai Chi in the real world, more or less. Although when you look at our inclusion and all that, it's not as pragmatic as you would hope. And then if they said, no, we don't have a preference, and we didn't know how many people would say that. Did we know that yet?
Yeah. So like for the latest cohort, we interviewed around 25 people, of which almost 21 had a preference.
Oh dear. This is a problem. So I want that summary data too, by the way. So for the ones who have no preference, which we're hoping would be more than that, they're randomized into the same two groups. So randomized mindfulness, randomized Tai Chi. This is your standard, RCT, where you can determine efficacy. Here we're determining effectiveness, right? And the other benefits of having a preference-based group for mindfulness and a randomized group for mindfulness, if we compare these two groups to one another, that's sort of looking at the effective preference, right? Sort of. Because what could you see happening? So why do we randomize? Why do we randomize in the beginning?
To control for any potential confounding variables, including ones that you could or couldn't even.
So that these two, sort of at the beginning, are the same, right? So they come from the same pool. Mm-hmm. So if some people have a preference and some people don't have a preference, do you think this group and this group are the same at the beginning? Are they going to have the same demographics, the same education, the same SES, the same gender, the same personality, the same everything? The people who choose an intervention versus the people who are willing to be randomized.
Oh, no.
I wouldn't say unless we compared them.
Well, we will, but I bet you anything they're different.
Yeah.
So that's a problem, right? So this comparison here of preference mindfulness to randomized mindfulness that should just be isolating preference is probably not, because the people in this group are going to be different from the people in this group from the beginning, right? So it's great, and it's pragmatic, but you don't have the control that you would if you randomized, right? And so then the same thing here. So if you compare the preference Tai Chi and the randomized Tai Chi, we're isolating the effective preference on Tai Chi, and then we can lump everyone together, right? So we can put together all the mindfulness people and all the Tai Chi people and compare those two groups and have larger sample size to do mediational analysis and all. So it's really cool, right? But then we got concerned. This was the original design. And then we got concerned that there's no treatment group. What if everybody just sort of improves the same? Then what? Right? We won't even know if it's because of our intervention. And then we added in all these biomarkers. So all sorts of stuff like gene expression and cytokines and telomere length and all this stuff. And so the cancer biology people were like, we really need a comparison group for these things because we don't know how they're supposed to move. So then we did this. So we added in a wait list to each condition. So now instead of 4 groups, we have 8 groups. Which was good in theory.
Stressful just to look at.
Yeah, well, these guys are running it, right? So now this is the preference side. So it's the same. These are the people with the preference. They either go into the mindfulness or the Tai Chi, right? But then they're further randomized into immediate or waiting. So this is chosen, but this is randomized. So that within our Tai Chi preference group, we should be able to have a comparison with the waiters, pre and post. Well, half of them are doing it. Actually, 2/3 of them are doing it, I think. Yeah, because the wait list is 2 to 1. So a smaller wait list. But so these guys are doing it. These guys are waiting. So that gives us a pre and a post for comparison, right? And then these guys who are waiting, they get to do it then later. So we can lump everyone together at the end and have larger sample sizes to compare the mindfulness and the Tai Chi. But the whole reason of adding in the randomized wait list was to hedge our bets in case both groups improve similarly, because then we would not be able to say anything about causality and efficacy kind of way. But if we were just being pragmatic, we would not have done this, right? There was a lot of conversation on the phone because I was going for this. I wanted this. But I got a lot of pushback, right? And if I knew then what I know now, I probably would have just done this, right? Because this is pragmatic. This is real world. In the clinic, well, I guess there are wait lists and stuff like that, but in the real world, people get what they want when they want it, typically, right? So because in the interest of explanatory and efficacy, that's why we did this. So I think I need to write a paper about our experiences. Anyway, we're partway through the trial, and things are going relatively okay. We're having a little bit of too much dropout from the people in the wait list, and yeah. So now let's assess it. How pragmatic is match? So whoops, I wanted to get out of here. Where did it go? There it is. Okay, so help me out here. So what's the criteria 1? Eligibility. So remember, 1 is total efficacy, 5 is totally pragmatic. So you guys know the eligibility. So the eligibility criteria are any cancer survivors, they have to be done treatment, but they can have any type of cancer except for brain tumors, but they can't be metastatic. So what do we get?
And they have to be distressed too.
And they have to be distressed.
So like middle but low maybe?
2 or 3?
Yeah.
3? I think
So,
okay.
sorry again, 1
is efficacy and 5 is pragmatic, right? Okay, so what's number 2? Recruitment. How much extra effort is made to recruit participants over and above what would be used?
4 or 5.
Oh no, we're going the other way. We're getting a 1 probably, or maybe a 2.
Oh, right, sorry.
What do you guys think? We're putting in a lot of effort to recruit these people.
Like a 1.
1.
Well, mostly what we're doing is sending out registry invitation letters. So I don't know if it's, I mean, we have a lot of staff screening and stuff like that.
If it was just the letters, then that would be...
It is mostly just the letters.
Just the letters.
But without the phone call component, you wouldn't have any... Like, isn't that an integral part
All
of
we're doing
recruitment?
extra for recruitment is sending out invitation letters.
Yes.
I think
Okay, so you're not incorporating screening as part of recruitment.
yeah.
We're talking to at least
Okay,
10
then like
we're going for
people a
2.
day.
I think 2 is the best we can do on that one. Setting. How different are the settings from the usual care setting?
It's not very different.
No, not, well, so it's tertiary cancer center. So would every cancer patient go there for their, and they all go there for their other treatments? So it's actually between 4 or 5.
Yeah, highest, because none of them have expressed a discontent over going to TVCC for their blood samples or something, because they go there all the time. It's like, yeah.
So the settings are 4 or 5. I'll just give it 4. Organization. How different are the resources, provider expertise, and organization of care delivery to the intervention group? So this is where we're putting in a lot of effort, right? So this is low.
Of the intervention.
Organization. So the resources, the provider expertise, the organization of care delivery in the intervention group.
Everything is top notch.
No, I know, but we're putting a lot of effort into it.
Yeah.
So it's 1 or 2, right?
Yeah.
It's not pragmatic. It's more.
Then what's the usual care?
There is no usual. Well, actually, there is usual care. So they call up and they're in the group. So usual care is they call. Well, actually, that's kind of true. So the provider expertise, I was going to say the provider expertise is really high, but it is for the clinical groups too, because we already have clinical groups.
Yeah.
So somebody could also do this, do the interventions without doing the study.
Yeah, they can. I guess I feel like,
Except Tai Chi, maybe.
well, if it was Tai Chi was a kind of program, like mindfulness is. It's interesting too, because you also have to think that most cancer patients don't get their treatment at a tertiary cancer center, right? You know, this is a bigger deal in the States, but most people go to these community cancer centers that doesn't really have this stuff, right? So it might be usual care at Tom Baker, but it's not usual care for everybody, right? So I don't know, I will go 3. Okay, and that's the next one. Flexibility and delivery. So it's pretty structured. There's a bit of flexibility. And the way that these interventions will be delivered in usual care probably are not that different, really. So I don't know, what do you guys think?
Yeah. So they can stop classes. That's the flexibility we offer, which might be there for regular programs as well.
It's manualized though, right? But it's not that different from usual care.
So I think it should be 4.
The only difference is like making an extra Tai Chi group and stuff to like meet the needs for the trial. So that's
Flexibility here. So how different is flexibility in how participants are monitored and encouraged to attend? So, I mean, we take attendance in all the groups, but if we call people who don't attend and remind them.
We do call them.
Yeah, so it's like it's only a 2. Like we don't let them go so easily, right? Follow-up. Okay, so our follow-up is, it's way more intensive than usual care, right? So that's like a 1 or a 2. 1 or a 2. It's probably 1.
Yeah.
Like we do a lot of follow-up. And all the blood samples and stuff like that. It's crazy. Primary outcome, relevant to participants. I think that's actually fairly pragmatic, right? Because our primary outcome is stress. So I think actually we get a nice 5 on that. The other outcomes maybe not. And then our analyses, we're actually all doing intent to treat, so this would be more. So I didn't set it up so we could do the wheel, but it's looking like it was supposed to be a more pragmatic trial, right? But in the end, we've ended up being fairly explanatory, and partly that's just because of the academic, the pressure, or what you feel like the pressure to be tight, right? So it's interesting. I think the next one we'll do it this way. We'll use the Pressy, we'll be pragmatic, and it'll be way easier. I think this is the last explanatory trial I'm ever going to do. Anyway, that was fun. So the last thing I want to tell you about, how's our time? That's good. We should be done maybe even a little bit early. And to get around that issue of the participants in the preference versus the randomized groups being different is called the doubly randomized preference trial, the DRPT, just for another acronym. So it's a hybrid, randomized and non-randomized design that allows blah, blah, estimation of the causal effect of randomization. So what they actually do is randomize people into a preference condition. Right? So everyone's randomized at the beginning, and you're randomized into being randomized, or you're randomized into having a choice. Yeah, so that way your preference group and your randomized group are equivalent because they're randomized. Right? So that gets around the issue of the people who choose being different than the people who want to be randomized. Right. So they're first randomized to either randomized or choice. Then in the randomized group, they're randomized treatment or control. In the choice group, they get to choose treatment or control, or treatment A, treatment B. So for this, and this paper that I attached to you, it's got all the math on how you can have an unbiased estimate of the effective preference. In the study we're doing, the effective preference is not clean, right? So if we go back to this design, because they're randomized into this or this, these two groups are equivalent. And then when you do this comparison, preference versus randomized, it's clean. And it really does isolate preference. But it's not as pragmatic, right? Because people don't actually get a preference. They may get a preference, but they may not, right? They don't guarantee you get a preference, like in our trial. So there's drawbacks. Again, these scientific people, it's like, well, we got to know, we got to isolate, we've got to be able to say causal stuff, right? So there's this tension between, that dichotomy, the pragmatic versus the explanatory, that is constantly going on, this push and pull, right? So I think it's quite interesting. So that's all I was going to talk about for today, so we can have a bit of a discussion about this if you guys have questions or comments.
So like if somebody's randomized into a choice group, but they don't have a choice, you just like provide them with info and you're like, make a choice.
Yeah, they're forced to make a choice. So it's making people choose.
Yeah.
Which is, again, kind of silly, right? Like in the real world, it's like you either have a preference or you don't.
Well, because you'd think that like the point of that is basically that like if somebody's getting randomized or getting put in a group in which they have a preference for it, then they're like less likely to drop out. So if you make somebody make a choice and they don't naturally have sort of a leaning, then would that be the scenario for them?
Well, you can look at that in this kind of design.
Yeah,
you look
totally.
at compliance, right?
That's interesting.
And my idea too is that in match, we're going to have better, you would think, treatment adherence in the preference groups than the randomized groups, right? Unless they get randomized to what they preferred, but most of these people didn't have a preference really, right? So you'd think that like in the mindfulness preferred group, you would have better attendance, better adherence than the mindfulness randomized group. And it'll be interesting to look at, I'm worried about the baseline characteristics being so different. And I'm also worried about the numbers, right? So if nobody wants to be randomized, you're not going to have enough people to even do a lot of those comparisons. So that's the issue too, is so now we have to adapt our design, right? Which we should have done at the beginning. So if we think of the ways we can adapt, right, from the last lesson on adaptive designs, how can we adapt this match study as we go along? Right. And this is a real question, right, because we're partway through the study. We're starting to get the data on how many have a preference and how many are ending up in each group. So what do we do?
I'm thinking about like preference being on a continuum and not just like dichotomous. I know it's something that's already been like kind of done, like tweaking how strong of a preference constitutes preference. But I wonder if there's a way to formally.
That's an interesting way. Well, so what we've done so far is the script initially when people were contacted was, we're comparing mindfulness and Tai Chi. Do you have a preference for one or the other? and most people you're sort of forcing them to make a preference. So we've changed it to, we're doing mindfulness and Tai Chi. Are you equally interested in both? Right?
Or would you be willing to take?
Yeah, but I think we may need to strengthen that approach.
Yeah.
Are you willing to take either? Are you interested enough in both that you'd be willing to be randomized or something? Like, I think we need to strengthen our wording. What are we saying now?
It's like we're just telling them that we are offering these 2 programs, and when they receive the registry letter and they call us back, they've sort of made up their mind what program they're going for. So they already have a preference when they're calling us to get details about the study. This is
why do they already have a preference?
They've read on the letter that what the math study is all about, and they have these 2 programs.
So maybe we need to change the letter.
Yeah. The next one.
Well, let's look at the letter then. Right? Because I want the data exactly on how many are choosing preference and choosing, and I also want to know which interventions are popular. Right? So say, what's your guess right now?
So this cohort is Tai Chi for sure.
Tai Chi.
Yeah.
This cohort, I want to know overall. I've been asking for this data. This is why it's important, right? Because we're going to have to adapt.
Yeah.
So overall, do we know?
We have the numbers for the previous cohorts, right?
Yeah.
We just have to sort of
So for
sum
the
up all
match
of
phone
this.
call, we need these numbers. Okay? I want this chart filled out with numbers. We need to know this because we need to discuss it with the study team.
Okay.
So say there's twice as many people choosing Tai Chi and 80% of the people have a preference. What are we going to do? Right? We have to adapt. How are we going to adapt? When are we going to adapt? What's the adaptation going to be? Right? So what are our options?
So
Again, if people have a strong preference, you can kind of maybe have a certain quota for preferred people who can take the group now, and then if they have a strong preference and too many people have a really strong preference, you can start to say okay, if you have a really strong preference, then the next time you can enter the randomization, that might make people more willing to okay, well I just want to do it now, so I'll be randomized to both.
Maybe. And Peter, the Tai Chi guy, his suggestion is more radical. He says you just close down certain arms. They're done. They're full. Sorry, no more Tai Chi. Unless you're willing to be randomized.
It's interesting you said the Tai Chi is more popular now.
Well, we don't actually know that.
Because in the beginning it was overwhelming.
Well, that's what I mean. They haven't looked at the data, right? So.
But I feel it's vary by cohort. The data, at least when I looked at it before, it varies by cohort.
Well, did you look at the numbers for preference in the first few cohorts?
Yes.
And what was it?
So it's mindfulness, the first few cohorts is mindfulness, and then...
how much more preferred?
So I guess I shouldn't analyze it before I say anything.
Yeah. We need the numbers. You can't make any decisions without the numbers, right? Which are right there. We need the numbers. So we need to make decisions too, right? So this wasn't included in the protocol, which it should have been. It should have been after we've accrued 200 people or whatever. We're going to sit down and we're going to look at making certain adaptations, right? So maybe if people aren't willing to be randomized, we need to shut down the preference arms, or we need to put a quota on the preference arms, or we need to change the allocation ratio, right? We need to do something to try and balance things out. So I don't know what we're going to do.
How about we tell them, ideally we would like to randomize you, but if you have a preference, we can consider that.
Yeah, that's why you don't have to say, I really want to randomize you. You have to change the wording of the letter and the recruitment script to try and, make that an attractive option to people, right? Are you willing to take either one of the interventions, right? Help us out here, be willing to take one of the interventions. That's the first question you ask them, right? Yeah. So sorry if they have a preference for Tai Chi.
What the reason is for their preference.
That's true actually too, because some of the preference is just logistical.
Yeah, and some of them have already done mindfulness or yoga in the past, so they want to try something new.
Yeah. Yeah, and then you could also look at rating how strong their preference is an interesting idea, even just to have the data, right?
Like a scale?
Yeah, or a visual analog scale, I prefer Tai Chi, I'm a 9 for Tai Chi, and I'm a 0 for mindfulness or something, right? I don't know if you could use it in randomizing people, because I don't know. This is all uncharted territory. No one has ever done a trial like this, right? So, Well, or crazy, some may say. I really wish we hadn't added in those waitlist things now that we're doing it. It's just so complicated, right? I mean, it'll be great once you have the data. You'd be like, oh, I wish we had a no treatment control, right? Because I don't know how to interpret these changes, you know, because that happens to people all the time. I see people presenting studies and they're like, oh, I just really wish I had a no treatment control. You know, I just did 2 intervention groups or something and I can't answer so many questions about it. So.
Today I was speaking to a patient. I think I've emailed you about that. So the patient herself is a yoga teacher.
Oh, I didn't see that one.
Oh yeah. So so in terms of eligibility criteria, and that's why she wants to do Tai Chi. So teaches yoga regularly.
But she's distressed?
Yes.
Interesting. And our exclusion, and again, you know, we tried to be broad, right, with the exclusion, but they can't have practiced mindfulness in the last month or something.
Yeah.
So she probably isn't.
Yeah, and that's, I think that's yoga in isolation. There's not mindfulness attached to it.
Right.
Yeah. So
Yeah, that's not on our list. You know, I mean, it might seem like the same thing. Interesting.
I guess if you're like teaching yoga, you might not be like, you know, like fully engaging in the actual practice of yoga. You'd be like telling everybody what to do.
Well, I mean, it depends. If you're a good yoga teacher, you are.
Yeah. Yeah.
But I was curious why he would want to sort of shut down the preference arm, like, and not do anything to the no preference arm. Because intuitively, I would think that you would want to taper the no preference arm out because it's not as popular.
Just so we could do the comparisons and have enough power
to
answer the research questions of the effective preference, right? But you're right, like in some adaptive designs, they would get rid of things that aren't working. I mean, that's a possibility too, right? I think we need to come up with all the possibilities, lay them on the table, and talk to the study team about what are we going to do, right? So we need all the data, like all the data, you know, in terms of dropout rates and, you know, what's happening in these groups, because we have enough people through now to have a sense of what's happening.
Yeah.
And then we have to come up with a list of possible options, pros and cons, you know, how practical, how pragmatic are these things, what's it going to do to our ability to analyze data, right? What's it going to do to our recruitment? You know, is it going to improve our missing data, right? Yeah, and I don't know, maybe that's another option. It's just drop the randomized, but that makes me sad, so. Anyway, it's a work in progress. So I think that was basically it for today. So it would have actually fun to do this on the little graphy thing that she showed, but we didn't have that. So there's a DRPT, yeah, and that's my last slide. Oh, so next class, we'll finish pragmatic trial designs, and we'll do some of the other ones that are often used. So the cohort randomized controlled trial, the stacked wedge, which is kind of cool. Like it's if you're going to introduce something anyway, you just do it in blocks. So that might be a relevant one to, you know, some of the exercise type things. And then we're going to get starting in patient engagement. So the next few ones are like patient engagement and dissemination, knowledge translation, that kind of stuff. Yeah, I think that's it. Yeah, and I guess the only things that I mentioned at the beginning in terms of traction stuff is if you've been done anything like conferences and that's in your learning plan, make sure you fill out the report template. I know a number of you have already, which is useful, and there may be other paperwork pieces going around once we figure out this complicated reporting thing that the CIHR is requiring of us.